ovulation induction agents, mechanism of action, indications, dosing protocols, and side effects. Introduction to ovulation induction. Ovulation induction is a key treatment for anovulatory or oligo-ovulatory women trying to conceive. Common causes of ovulatory dysfunction include polycystic ovary syndrome, PCOS, hypothalamic amenorrhea, hyperprolactinemia, unexplained infertility. Three primary classes of ovulation induction agents: clomiphene citrate, CC, selective estrogen receptor modulator, SERM, letrozole aromatase inhibitor, gonadotropins, exogenous FSH and LH injections. 1. Clomiphene citrate, CC, mechanism of action, selective estrogen receptor modulator, SERM, blocks estrogen receptors in the hypothalamus, disrupts negative feedback, increases GnRH release, stimulates FSH and LH production, promotes follicular development and ovulation. Indications: first-line treatment for PCOS-related anovulation. Used in unexplained infertility to induce ovulation. Induction of ovulation in women with irregular menstrual cycles. Dosing protocols. Starting dose 50 milligrams per day, orally for 5 days. Cycle days 3 to 7 or 5 to 9. If no ovulation, increase to 100 milligrams per day up to 150 milligrams per day. Ovulation typically occurs 7 to 10 days after the last dose. Maximum recommended duration 3 to 6 cycles. Success rates: ovulation rate 70 to 80%. Pregnancy rate per cycle approximately 15 to 20%. Side effects: anti-estrogenic effects on cervical mucus and endometrial lining, may impair implantation. Increased risk of multiple pregnancies, approximately 5 to 10%. Hot flashes, mood swings, nausea, rare. Ovarian hyperstimulation syndrome, OHSS. Limitations: not effective in hypothalamic amenorrhea, low GnRH production. May not work in CC-resistant PCOS patients. Switch to letrozole or gonadotropins. 2. Letrozole, aromatase inhibitor. Mechanism of action: inhibits aromatase enzyme, prevents conversion of androgens to estrogen. Low estrogen levels reduce negative feedback on the hypothalamus, increases FSH release, stimulates follicular development and ovulation. Indications: first-line ovulation induction for PCOS, especially in CC-resistant women. Alternative for women with poor endometrial response to clomiphene. Used in controlled ovarian stimulation for IUI or IVF cycles. Dosing protocols: starting dose 2.5 milligrams per day, orally for 5 days. Cycle days 3 to 7 or 5 to 9. If no ovulation, increase to 5 milligrams per day up to 7.5 milligrams per day. Ovulation occurs approximately 7 days after the last dose. Success rates: ovulation rate 75 to 85%. Pregnancy rate per cycle approximately 20 to 25% higher live birth rates compared to clomiphene in PCOS. Side effects: mild nausea, dizziness, fatigue. Lower risk of multiple pregnancies, 1 to 3%. Shorter half-life, fewer persistent anti-estrogenic effects than clomiphene. Limitations: not FDA approved for ovulation induction, off-label use. Less studied in non-PCOS patients. 3. Gonadotropins, FSH and LH injections. Mechanism of action: exogenous FSH and or LH stimulate follicular development directly. Bypasses hypothalamic pituitary axis. Indications: women who fail oral ovulation induction, clomiphene or letrozole. Hypogonadotropic hypogonadism, low FSH-LH secretion. Controlled ovarian stimulation in I or IVF cycles. Dosing protocols: FSH alone, recombinant FSH, RFSH, Gonal-F, Folistim. FSH plus LH combo. Human menopausal. Gonadotropins, HMG. Menopur, HCG, human chorionic gonadotropin, used as a trigger injection for ovulation. Given as daily injections starting on cycle day 2 or 3. Dose adjusted based on follicular response monitored via ultrasound. Success rates: ovulation rate greater than 90%, pregnancy rate per cycle approximately 20 to 30%. Side effects and risks: higher risk of multiple pregnancies, 15 to 30%. Increased risk of ovarian hyperstimulation syndrome, OHSS. Injection site pain, bloating, mood changes. Limitations: requires close monitoring, ultrasound and hormone levels. Higher cost than clomiphene/letrozole. 4. Comparison of ovulation induction agents. Agent, mechanism, success rate, multiple pregnancy risk, endometrial effect, best for. Clomiphene citrate, estrogen receptor blocker, FSH and LH. 70 to 80% ovulation, 15 to 20% pregnancy, 5 to 10% thin endometrium, PCOS, anovulation, letrozole, aromatase inhibitor, estrogen, FSH. 75 to 85% ovulation, 20 to 25% pregnancy, 1 to 3%, no anti-estrogenic effect, PCOS, clomid resistance, gonadotropins, direct FSH/LH stimulation, 90% ovulation, 20 to 30% pregnancy, 15 to 30% no effect, clomid/letrozole failure, IVF. 5. Future innovations in ovulation induction. AI-based dosing algorithms, personalized medication dosing based on hormone levels and follicular response. Low dose step-up, gonadotropin protocols, lower OHSS risk while optimizing ovulation. Adjunct therapies, metformin for PCOS patients to improve insulin resistance. DHEA supplementation for poor ovarian responders, Conclusion: ovulation induction agents. Clomiphene and letrozole are first-line oral agents for ovulation induction. Letrozole is preferred in PCOS due to better endometrial effects and lower multiple pregnancy rates. Gonadotropins offer the highest success rates but require intensive monitoring and higher costs. Choice of agent depends on patient characteristics, response, and financial considerations.